Hello, welcome. My name is Gursimran Singh Kochhar, and I'm one of the gastroenterologists at Allegheny Health Network. I am a therapeutic endoscopist, and I also manage complications in IBD patients. I would like to thank Dr. Guillermo Vitia and the whole Venezuelan Gastroenterology Society for giving me this opportunity to share with you my topic, newer innovations in endoscopic management of strictures in IBD. We'll be discussing the role of endoscopic stricturotomy predominantly. I have no financial disclosures. We will start with the case. A 32-year-old young female with ileocolonic Crohn's disease, status post resection, is now presenting for management of anastomotic stricture. She's 9 months postpartum. Stricture is at TI at the anastomotic site, approximately 1 centimeter in length. She's currently maintained on biweekly adalimumab for her Crohn's disease. She was recently hospitalized secondary to partial small bowel obstruction. She did undergo a balloon dilatation to 15 millimeters with minimal relief in her symptoms. CT enterography shows a mild stricture, mild presynoric dilatation, and some mucosal enhancement. This is the stricture on the colonoscopy view. For this patient, what would you recommend? Repeat balloon dilatation with injection of steroids, do an endoscopic stricturotomy, surgical resection, switch medications from anti-TNF. I want you all to register your answer, and we will come at the end of the discussion, and we will see what we did with this patient. So strictures are luminal narrowing that lead to partial or complete obstruction. They result from long-standing inflammation. Terminal ileum and ileocolonic junctions are the predominant location of strictures, followed by anastomosis. 5 to 24% patients have stricturing phenotype. Till date, there is no effective medical therapy, and surgery has been the gold standard. Three main types of stricture. One is a web-like, the B is a spindle-like, and C is the ulcerated stricture that we all very are concerned about. So endoscopic stricturotomy is a technique in which we use electroincision to widen the lumen of the bowel. Needle knife has been commonly used in ERCP procedures. Same needle knife was used to perform radial, horizontal, or circumferential fashion cuts in the strictured lumen to do endoscopic stricturotomy. Our global intervention IBD group, led by Dr. Shen and myself, we recently published our first guidelines in Lancet Gastro and Hepatology, where we described endoscopic stricturotomy, in which the stenotic lumen of GI tract is widened by incision alone, and endoscopic strictureplasty, in which we not only widen the lumen, but we also put clips at the end of the procedure, to maintain the patency of the lumen and prevent the edges to go back together. What are the goals of stricturotomy? It is to improve obstructive symptoms, improve drainage symptoms. We want to reduce complications related to stricture like a fistula formation. It's an add-on to medical or surgical therapy. I think the main important point is that we are trying to space the need out for surgery. Endoscopic stricturotomy is not there yet to replace the surgery. I use these two most commonly knives, IT nano knife and hook knife, and I use ERBI settings with EndoCut Q313. So this is a patient who's 32-year-old with Crohn's disease sent to us with anastomotic stricture. The patient is having partial obstruction symptoms. As you can see, I'm trying to advance my colonoscope. I was not able to. It's an end-to-side anastomosis. So we decided to go ahead and perform stricturotomy in this patient. We are using an IT nano knife in which my goal is to do a circumferential cut, 360 degree to widen the lumen. I determine the cut length once I start seeing the muscle fibers. I usually tend to stop, but if you see any fibrotic tissue, you can cut the entire tissue. So we have done the upper margin first, now we're doing the lower margin. And once the cut is enough, we are able to advance the scope into the small intestine. This is the small intestine lumen. The lumen looks pretty nice. There is no signs of inflammation. So predominant symptom the patient was having was because of the blockage at this anastomotic stricture site. Once the procedure is done, as I mentioned, I like to put these clips in a circumferential fashion again, if possible. They prevent the edges from going back, and they also help to reduce post-procedure bleeding risk. The first concept paper was published by my mentor, Dr. Shen from Cleveland Clinic, in which he discussed 85 patients. Anytime a new technique comes, we are worried about two things. Where can this technique be used? What are the adverse events? So this flowchart shows that this technique can be used predominantly for any of the IBD patients, for the primary strictures, for secondary structure, for pouch structures, for fecal diversion structures, to inlet structures. And as I mentioned, the adverse event rate. In this initial experience, the adverse event rate was 3.7%. Perforation was seen in one patient, which was very early on in the disease, and 9 patients had bleeding, which was described as need for hospitalization, need for blood transfusion, need for repeat intervention, which is, for me, is bleeding is a risk, but I think the risk of perforation really goes down, and we're going to see further. How does structurotomy compare to ileocolonic resection? In this paper, they studied 35 patients with structurotomy and 147 patients with ICR. The main thing take home is obviously the follow-up time is longer for ICR patients. But if you look at the symptomatic improvement, was more in ICR patient versus structurotomy patients. But disease-associated surgery or structure-related surgery was not different in the two groups. That was same. The p-value was 0.83. In the same study, they did then propensity matching, and even after propensity matching, the structure-related secondary surgery is still same in both the groups. 1 patient in structurotomy group, 2 in ICR group. P-value was not significant, but that is the strongest take-home message for me from this paper. How does structurotomy compare to balloon dilatation? Again, we see there's a significant difference in the follow-up time. Obviously, structurotomy is a new technique, but again, if you look at the immediate technical success, it is 100% for structurotomy, approximately 90% for balloon dilatation. Symptomatic improvement in structurotomy group is higher than the balloon dilatation group. And if you look at the complications, again, perforation is less, it's almost zero in structurotomy group. Balloon dilatation had 2.4% rate of perforation, and bleeding was significantly higher in the structurotomy group, approximately 14.3% compared to 0 patients in endoscopic balloon dilatation group. When we look at 5-year surgery-free survival between endoscopic structurotomy and balloon dilatation, for the first 3 years, endoscopic structurotomy definitely tends to fare better than endoscopic balloon dilatation, but after 3 years, the curves both seem to merge, indicating that the effect after 3 years seems to be same between balloon versus structure group. What has been my experience so far at AHN? We have done 43 cases, locations from upper GI tract to anal canal structure, pretty much everywhere in the GI tract. We have achieved technical success defined by passage of the scope during the procedure in all patients. Clinical success defined by not requiring a need for structure-related surgery in 97.6% patients. 3 patients had post-procedure bleeding, which self-resolved, no perforations. The longest follow-up period is 22 months. 1 patient ended up requiring a surgery because of the pouch failure. In my opinion, the structurotomy has advantages that it preserves the bar length. You have more control. In a balloon dilatation, when you let your nurse or tech know that go up to X size of the balloon and the balloon expands, the radial force is transmitted. There is no way to take that force back. Whereas in endoscopic structurotomy, you control the knife, you control the length of the incision. It depends on you how deep you want to cut. So I think that is one of the biggest advantages I feel with structurotomy. Now we know it's a similar surgery-free survival as resection. And I think it is very, very good for anal strictures. Anal strictures have always been very hard to manage. We either recommend patients do self-dilatations or we do balloon dilatation. Repeated self-dilatations can cause incontinence because of nerve damage. This, in my opinion, is a very big advantage. Here we'll share a case with an anal stricture in a patient with PSC, and UC now has a J pouch. The stricture was so tight, you can't even do a digital rectal exam, and upper EGD scope will not go through. We decided to perform structurotomy, again using the IT nano knife. The key in this female patient was to cut in the opposite wall from the posterior vaginal wall. I do not like to cut on the posterior vaginal wall side, just in case if there was more tissue damage from heat, there is a risk of causing pouch vaginal fistula, which can be very difficult to treat. So once you've identified the posterior vaginal wall, you go on the opposite side to cut the stricture. In this case, my intention was to cut semi-circumferential and not full circumference. And just after a little bit of cutting the fibrous tissue, we barely reached till the muscle. We were able to advance our scope through and then examine the remainder of the pouch. And as you can see, the pouch is inflamed as there was fecal stasis. Patient was having symptoms. The stricture immediately looks bigger than before. I have followed this patient since now it's been almost an year. She's had repeated two pouch exams with me. I had to not do more any cutting. Stricture is still widely patent. So this is so far the emerging data in stricturotomy and IBD. My main take home point in this is the column on the far right, that's the adverse events. If you look at all the adverse events, the highest rate has been described as 10.2%. Majority of these adverse events are bleeding. Very minimal, maybe one or two patients who have had perforation. Most of the patients come with bleeding, which is inconvenient to patient, which is repeated hospitalization, but bleeding is something we can manage endoscopically on most of the occasions. Can we combine stricturotomy and balloon? Yes, I have done that. In this video, we will share a difficult, tough stricture at ileocolonic anastomosis. I initially started to do a knife incision, and I was trying to cut, looking at the fibrous tissue. I was not able to find the fibrous band because the lumen of the small intestine kept prolapsing out. So then I decided to snare off this mucosa of small intestine. And after this was cut, I tried to resume my cutting with the knife. As you can already see, we are at the level of the muscle here, and still I'm not able to advance my cutting any further. So at this point, when the stricture was so fibrotic, I did not get enough leverage to cut more. I decided to do a balloon dilatation. I did dilate the balloon up to 15 millimeter. Excuse me. I do not do these dilatations under fluoroscopy, but if you would feel more safer to do them, you can do that. I always like to see within the bar length, the balloon, as to how much expansion has happened. I like to see that whiteness of stretching of the mucosa. That indicates me the stretch has been pretty good. And after that has been done, like right here, we see that white dispersed fibers. This tells to me that we have stretched it enough. And right now, the opening looks much different, much bigger than before. And then we try to maneuver our scope. Most of these locations are not easy, as you can appreciate, because we are in a retroflex position given the end to side anastomosis. This patient had some inflammation also because of, I think, fecal stasis. And as mentioned before, I like to use clips, and I clip close where I did the highest cutting. So drawbacks, this requires some training, some expertise. In United States, currently we do not have any billing codes for this procedure, so it is not widely accepted. It can be time consuming compared to balloon dilatation because in balloon dilatation, people are so comfortable, your nurses, your techs, everybody is so comfortable that we can achieve balloon dilatation very easily. Complications, yes, bleeding is still a cause of concern. We are trying to figure out ways how to minimize the bleeding. I have changed some of my cutting settings on Irby machine. Still, I have not been able to come around and reduce the rates of bleeding. People always ask me, how do I approach a patient in our interventional IBD unit who comes with a stricture? I follow this algorithm. It's much more simplified. So we obtain a pre-procedure imaging. If the size is less than 3 centimeter, I favor endoscopic stricturotomy. For strictures longer than 3 centimeter, I like to balloon dilate, get on the other side of the anastomosis or the stricture, and then on my way back, decide, do I need to cut any fibrous part? If there's a lot of inflammation, it does help to medically optimize the patient before you do any cutting. But if the patient has significant pre-stenotic dilatation and stricture length is more than 5 centimeter, the data shows in those cases endoscopic stricturotomy is not as useful and we should consider surgery in those patients. Coming back to the case that we discussed before in that patient. So in that patient, we decided to do endoscopic stricturotomy. This is the video of that case. This was actually our first patient at AHN that we did this procedure on. As I mentioned, the scope was not able to pass through. Even if I tried a little bit, there was scope trauma. So again, using an IT nano knife, we started cutting the stricture. My goal is to start semi-circumferential cut. And if I can make a circumferential cut afterwards, that I found it to be more useful. But people have cut it radial, both sides, or they have made just one horizontal cut into the muscle. Once I start seeing the exposure of the muscle fiber, I usually tend to stop. In this case, I'm trying to now go circumferential. And as you can appreciate, there is some loop in the scope that always happens in a post-op anatomy in IBD patients. There we have made a deep cut up to the level of muscle. And once you cut up to the level of muscle, the stricture tends to give away. I had to do a little bit more cutting. And after that, we were able to easily pass to the small intestine lumen side and examine the small intestine lumen. So here we are in the TI, and we can deeply intubate into the TI after that. And this patient again had normal mucosa, so there was no need for her to undergo a repeat surgery. As I also mentioned in the case, she was 9 months postpartum, so she wanted to avoid surgery at that time. And then we tend to close it with the clips. As I mentioned, clips work twofolds. They prevent the edges to go back, and they also help in the post-procedure bleeding. This is 1 year follow-up of the same patient. You can see the stricture is much more wider now. My scope went in easily with no issues. I was able to intubate T at 10, 15 centimeter. She has been now 22 months out of the initial procedure, has not required any surgery. Future direction for strictures looks very bright. We are now, I think, in a phase that we can start testing for drug-eluting balloons. Drug-eluting stents are coming, I think, for biliary strictures soon. I think we can translate that into even the luminal strictures. I'm already using 3D printing for stricture models, as 3D prints give me the length of the stricture, the angulation, where the blood vessels are, so I can plan my procedure accordingly. In conclusion, I think endoscopy is and will now be continue to be a major player in management of IBD, not just for diagnosis or dysplasia management. We should now be managing IBD complications with endoscopy. And I think one very important point is, as our technology is getting better, our skill is getting better, we need to train our colleagues and our fellows to learn these techniques in a better way. So we have formed a special interest group in under the flagship of ASGE, in which we discuss these techniques and arrange for our SIG members to learn these techniques. Finally, I would like to invite you all. We are having our second annual AHN IBD Summit on November 14th. It's a star-studded lineup of IBD faculty, including Dr. Brian Fagan, Dr. Hanover, Dr. Rubin, Dr. Sands, Dr. Shen, Dr. Ramsey, Dr. Flashner, and Dr. Dulay. The conference is available in Spanish language. There'll be live translation in Spanish language, and it's free conference. Please register if you can at cme.ahn.org. With that, I would like to thank once again all of you for giving me this opportunity to discuss briefly with you the role of endoscopic stricturotomy in IBD patient. I once again would like to thank Dr. Guillermo Veitia for inviting me. I would like to thank the Venezuelan Gastro Society. This picture is from my hometown, back home in state of Punjab in India. This place is called Golden Temple. So if you ever happen to go to India, must make a point to visit there. I'm sure you will enjoy it. With that, I would like to conclude, and I'll be happy to answer any questions. Thank you so much.